Okay. Good afternoon, everyone, and thanks for joining us. For those whom I haven't yet met, my name is Elise. I use she, her pronouns, and I'm a Public and Community Engagement Knowledge Translation Officer on behalf of the Science Office and the Equity and Focus Core Working Group. Thank you so much for joining us for another session in our Equity and Focus speaker series. We ask that you please remain on mute during today's presentation, but we welcome you to unmute when we reach the question and answer stage. Today is our first session for 2024, and our focus this year is on the nuances of the race-related variables that currently exist in ICS's data holdings and how these data can be used to uphold the principles in the guidance document and framework for anti-racist approaches to research and analytics. Over the coming months, you can look forward to several sessions that each dive into a different data holding. So we're here today to talk about Immigration, Refugees, and Citizenship Canada, or IRCC's Permanent Resident Database. Before jumping in, I'd like to take a moment for us all to reflect on the land where we're privileged to live and work. For me, that's the city of Toronto, which was built in the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. If, like me, you were born or grew up in Canada, the instinct can be to think of this place as home and not to think of ourselves as immigrants. But as our speakers today explore the more contemporary pathways of immigration reflected in our IRCC data, I'd encourage you to also think about your family's own immigration pathway, especially if it was 3, 5, or 8 or more generations ago, and reflect on the duty of all settlers to recognize ourselves as such and build towards reconciliation with our First Nations, Métis, and Inuit neighbors. With that, I'm now pleased to introduce today's speakers, who may be familiar faces to many of you. We'll be hearing first from Alison Park, who is a senior epidemiologist at ICES and an algorithms and harmonized data epidemiologist with HDRN Canada. She maintains ICS's new inventory of race-related variables within the data repository, which you'll be hearing more about shortly. And we'll also hear from Associate Research Methodologist, Dr. Hong Liu. As our subject matter expert for the IRCC data, she provides support and insight for staff and scientists and serves on the IRCC Data Working Group. And we're also joined today by Dr. Susitha Wanigaratne, ICS Fellow and Senior Research Associate at the Edwin S.H. Leong Center for Healthy Children. Her work as a social epidemiologist examines immigration as a structural and social determinant of health. So thank you all so much for sharing your expertise with us today. And I'll hand the floor over to you, Alison.
Okay, thank you. I'm just going to share my screen. Hopefully you guys can see that. Okay, thanks. So I'm just going to be talking about just a few slides about the ICS inventory of race and related data. So basically, it's just a spreadsheet inventory that lists the ICS data holdings with that have race-related identifiers in them. It also includes some information about the method of collection, whether it was self versus provider reported, or if it was derived, how it was derived. It also includes the level of capture, so if it was individual versus aggregate, and the degree of missingness, which comes from the ICS VMO reports. It does not describe Indigenous identifiers. This is because we at ICS have different policies and approaches to reporting on Indigenous information. So for that, you should see the ICS intranet, and I put the link here as well. So in terms of where you can find it, it's the inventory is under the research and data, resources for anti-racist research. If you look under tools, there is a link to the spreadsheet. It's called Inventory of Race and Related Data within the ICS repository. And there's also a direct link here to the spreadsheet as well. So I just took a screenshot of the summary page from the spreadsheet. So basically, the results on that page are from a scan of the ICS data sets, along with variables and formats. We look for race-related keywords such as ancestry, race, country of birth, ethnicity, visible minority. You can see the list of keywords here at the top of this first table. There are 3 tables on the summary page. So there's one that shows which data sets or which data holdings have keywords in their data set name. And then there's a table for keywords found within variable names. And then there's another table which would be below this one, which I'm not showing. It shows which data holdings have keywords in the formats. So you can see in the, I'll just skip down here to the second table. When we looked at keywords found in the variable names or labels, we identified within the CIC database, which is the last row, we found 2 variables that have country of birth in the variable name or the variable label. So that's an indication of that there's obviously race-related information in that data set and how many variables actually contain that information. And if you wanted to find more information, there are additional pages within the Excel spreadsheet where you can look for the exact variable that contains that information if you want to know the exact name of it. There's also an extension to the table on the summary page. If you scroll over to the right, you'll find more information. So information includes percent not missing, the record level, collection method, etc. And I'm going to point out for the CIC database, because that's what we're talking about today, that 100% of the records are recorded. It's individual level and it's self-report data. One thing I'd like to point out about the percent not missing column is that it means that that information is documented, but it doesn't mean that it's necessarily known. So for example, not missing may include undefined, unknown, refuse to answer, those types of values. So if you want to be sure, go to the VMO report on the intranet page to find out exactly the distribution of the values that are in those variables. So that's really it for my part. I welcome any questions or feedback that people have. If you don't have it now, you can always contact me at my email address here. And I'll pass it back to Elise.
Thanks so much, Alison. We'll move right into kind of the meat of our presentation from Susitha and Hong now. So over to you, Susitha.
I'm sorry. Thank you, Elise, and thank you, Alison. Let me just share my screen here. Sorry, just give me 1 second. Okay. Just getting my screen set up so I can see people if I need to. Sorry, everyone. All right. So yes, thank you all for attending today. Hong and I are looking forward to speaking. Just a quick reintroduction, Hong will be talking about the IRCC data after myself. Again, my name is Susitha Wanigaratne. I'm a Senior Research Associate and Social Epidemiologist at the Edwin S.H. Leong Center for Healthy Children. So today we like to declare first that we have no conflicts of interest. And here's a bit of an outline for what we're going to be speaking about today. So I wanted to start off with understanding how immigration fits into the social determinants of health framework, and specifically that World Health Organization framework that we often see. So I will talk about that. I'll also talk about how we can understand immigration as a social and structural determinant of health. And then Hong will take over and talk about specifics in relation to the IRCC database. She'll talk about data elements, data quality. We'll talk a bit about how that database intersects with the guidance around anti-racist approaches for analytics at ICS. And then we'll end with some recent examples about with some work that Hong and I have been working on in relation to IRCC data and vaccine coverage and severe outcomes among immigrants in Ontario. So here's the conceptual framework that I referred to, and many of you are likely familiar with it. This is from, again, the World Health Organization. And I won't orient you to it because hopefully you know you're familiar with it. But this is what it looks like. And it doesn't specifically call out immigration. And I just want to kind of specify where I think it intersects with this particular framework, especially in the context of Canada, in that, immigration in Canada is primarily related to public policy, specifically related to macroeconomic policy as well as labor market policies. And that's because immigration is a huge driver of economic growth and economic stability in Canada. And this is primarily through immigrants working in the labor market, contributing to the economy. I think another important aspect to think about is that, what shapes that immigration policy is essentially, Canadian culture and cultural and societal values. And I'll talk a bit more about that in the next slide, in the next few slides, actually. So I like to start off with talking about Canada's immigration history. And, if many of you are familiar with the quote, "You can't know where you're going until you know where you've been." That's a quote by Maya Angelou. I find it very important in thinking about that relative to Canada's immigration history here. So, all the information on this particular slide is based on information from the Canadian Museum of Immigration at Pier 21. And that physical museum is in Halifax. And if you haven't had a chance to go to it, I went to it years ago and I found it really interesting and engaging to think about how the many trajectories of immigrants coming to Canada. But I wanted to, in perusing that website, one particular quote really stuck out at me, and that's this one on the screen here. And that it is that immigration legislation is ultimately a reflection of society's beliefs and attitudes, revealing Canada's history of inclusion and exclusion. And I found it striking because I think many of us think of immigration to Canada as inclusive and kind of always being that way. But I think when you think about the history of immigration to Canada, and even now, you can think about it both as inclusion and exclusion. So there are a few immigration policies listed on the screen there that occurred after Canada's Confederation. So these are after 1867. And the first one that many of you may be familiar with is the Chinese Immigration Act that was implemented in 1885. And this was essentially a head tax that was placed on all immigrants who wish to come to Chinese immigrants that wish to come to Canada. And this is really despite, the 17,000 Chinese laborers that built the Canadian Pacific Railway in British Columbia that, that were started in about the 1880s. So it's striking to think about Chinese laborers, in many cases dying, building that railway, but then ultimately the government decided to place this head tax to limit further immigration from China. So it's, one of the important historical manifestations of immigration policy in Canada. There's others on the screen there. The second bullet there is the Continuous Journey Regulation of 1908, and that was focused mainly on preventing Indian immigrants from coming to Canada, and it did so because Indian immigrants had to have multiple boat journeys in order to come to Canada. So if you had more than one, you were essentially prevented from coming to Canada. And the third one on the screen there is Order in Council from 1911. And it banned Black immigrants from coming to Canada because they were deemed unsuitable to the climate and the requirements of Canada. That's from the policy itself. So really explicit discriminatory policies against specific groups, immigrant groups coming to Canada. And it took about 100 years after Canada's Confederation for the government to realize that these were very explicitly discriminatory. And it also recognized that the economic needs of the country were also shifting, and they wanted to restructure immigration. That occurred in 1967. So this is what that policy looked like. It moved to a more objective admissions process, less explicitly discriminatory. It was based on 9 categories. Some of them are listed on the screen here. So education, training, personal character, occupational demand and skill, age, French, English language were a few of the characteristics to a few of the criteria they used. So this is essentially the predecessor to the current system for selecting economic immigrants into Canada. And in a few slides, I'll talk about some of the explicit criteria that shape the sponsored family and refugee pathways. But those are also you can think of those as including some groups and excluding other groups. Really, my point in recounting this history with you is really to demonstrate that immigration policy is a structural force in shaping who comes to Canada, and it is also very highly selective in ways that have varied over the years of Canada's history. And throughout this history, the primary purpose of immigration has also been to fill economic needs and to enhance prosperity of the country. So this slide here just gives you, this is from Statistics Canada, and it gives you an idea of the origins of immigrants throughout Canada's history, mainly since Confederation. So I put that timeline that I reviewed along the bottom of the slide. So you can see that for the first 100 years of immigration to Canada, immigrants that were included in the immigrant makeup were largely from the United States, Europe, and Britain. And then really when that 1967 policy was implemented, you could see that the diversity of Canada has changed drastically until this, it's much more diverse and includes the rest of the world essentially. And this graph ends in 2011, but that diversity has continued to increase in the last 20 years. So in terms of what permanent residents look like in Canada today and their application criteria, in our work, the work that Hong and I have done, we essentially use, and others obviously, the 3 categories that we tend to focus on are firstly economic immigrants, and in any given year, about 60% of immigrants, permanent residents to Canada are economic immigrants, and again, they're selected based on that point system that I referenced in a previous slide. There's also sponsored family, and that's about 30% of permanent residents in any given year. And as their name would suggest, they're sponsored by Canadian family members, and those family members are actually financially responsible for those family members for, I think, around 10 years. There's also refugees, and in any given year, there are about 10% of permanent residents to the country, and they meet United Nations definition of a refugee. Refugees can be further broken down into a couple of other subgroups. There's resettled refugees, and they're permanent residents on arrival. Within this group, you can break them down into sponsored and government-sponsored refugees, as well as privately sponsored refugees. Government-sponsored tend to be based on a vulnerability criteria that the UN has set up to select, refugees that are in need of resettlement. Private sponsoredly refugees are a little bit different in that they are sponsored by a group in Canada and support them through the first year in the country. And often these refugees actually have family in Canada already who primarily came through the government-assisted refugee pathway. There's also refugee claimants, also known as asylum seekers, which you hear a lot about more in the news. And they are temporary residents on arrival, and they come here unsponsored. They don't have anyone supporting their immigration to the country. And only when they have successful immigration hearing, refugee hearing, they become permanent residents. But again, there's no one helping them, identify or identify health service pathways or anything like that. And for all these permanent residents, they can apply for citizenship if they meet specific eligibility criteria. I also wanted to talk a bit about the immigration medical exam and how that can offer information into inadmissibility criteria to Canada. So all immigrants who are coming as permanent residents, they have to do an immigration medical exam, and this also applies to some temporary residents. There are 3 possible reasons that the government will decide that immigrant is inadmissible to Canada, and this is based on the information that comes from the immigration medical exam. The first is that they're a danger to public health. Essentially, this is related to if they have certain communicable diseases, if they're a danger to public safety, and this is identified as unpredictable or violent behavior, or if they are projected to exceed a threshold for anticipated use of health and social services. So this is what is referred to as excessive demand, and it's essentially a monetary threshold. So economic immigrants and most family class immigrants are inadmissible if they are deemed to potentially exceed this threshold. Refugee claimants cannot be rejected based on this excessive demand threshold. And as of 2002, resettled refugees and some family class also cannot be rejected based on their anticipation of exceeding this threshold. And some other information related to that is that this policy has shifted in like the last 10 years or so, and in 2018, that excessive demand threshold has tripled. So now in 2002, it was about $25,000 a year in anticipated healthcare and social service use. And I also wanted to talk briefly about temporary residents, even though they're not available in the current file. Hong will talk about that in more detail when in her section. But just to give you a bit of an idea about temporary residents, this includes temporary foreign workers, international mobility program folks, international students as refugee claimants. They cannot apply for citizenship. They have to go through a PR pathway first. And temporary foreign workers, a subgroup of temporary residents who are often deemed unskilled, they have few pathways to permanent residency, and an exception for that is the caregiver stream. And many of you might recall that temporary foreign workers were in the news a lot during the pandemic, specifically migrant agricultural workers. And there has been some work to make their living conditions and working conditions safer. But recently, this Twitter screen capture is from just September of last year, and there's a United Nations special procedure group that still identified that the temporary foreign worker program is a breeding ground for contemporary forms of slavery. Not my words, the words of this organization. So just to highlight that there's lots of heterogeneity within this temporary resident group of varying experiences. In terms of recent immigration trends, permanent residents for many years, it was capped at around 250,000 immigrants a year. As of around 2015, this has increased to around 300,000 since 2021, essentially in response to keeping economic growth optimal in Canada. The government has decided to up the levels to around or over 400,000 a year, and I think next year it's going to be around 500,000. In terms of temporary residents, you'll see I put a graph on the screen there just to show the growth. That's that upper blue bar there that just shows the growth in temporary resident permits over the years. And the 2021 census actually enumerated about 1 million temporary residents in Canada. So before I go on to talk about the social determinants of health that are more proximal to health. So I've talked about kind of how policies can shape, the immigration streams. I'm going to move on to talking about the social determinants of health more proximal to immigrants here. And that World Health Organization framework is helpful, but I also like this diagram in that it more explicitly calls out, those wider set of social forces that shape daily conditions. So just to orient you to this, what people in Massachusetts who had developed this is called the health equitree. The leaves are, health outcomes that we're all familiar with. The health behaviors are those branches. The trunk is those social determinants of health that we often talk about: employment, housing, etc. But I feel what is often not explicitly called out is these root causes. So, sexism, classism, poverty, racism. And then you'll see that I circled xenophobia. And for those who don't know what xenophobia means, it's the dislike or prejudice against people from other countries. So it's essentially, a dislike of people in the IRCC database. So there's a root cause that can influence their health, and it's referred to as xenophobia. And I don't have a screen capture of the study here, but Dr. Shazeen Suleiman did a literature review that was published in 2018 that that said that xenophobia is definitely a political threat. We hear a lot about it in the news, but it also has a very real impact on the health of individuals and communities. So I just wanted to point that out in relation to this figure as well. So if you're interested in learning more about immigration as a social determinant of health, as a structural determinant of health as well, this paper is wonderful. Highly recommended review from Annual Reviews of Public Health, published in 2015. It is US based, but I find it super very helpful in framing and understanding how immigrant health literature describes what is causing poor health among immigrants. So it did a deep dive into looking in the literature and tried to identify what frameworks commonly used to explain immigrant health. So the most common framework is the health behavioral framework. And, these authors describe that it perpetuates narratives of personal responsibility and that, poor health for immigrants is based on a lack of education, a lack of self-esteem, a lack of self-efficacy. And the example they give around is around child nutrition. And that, literature tends to focus on the importance of modifying parenting practices while completely ignoring the fact that immigrants may have limited access to healthy and affordable food. Another framework that is commonly used, often in relation to the health behavioral framework, is the cultural framework. So it describes group traits, shared beliefs, and values that are explicitly linked to race, ethnicity, and those are what influences the individual behaviors and choices of immigrants. And what I think is important and what I often see in immigrant health research is that, there's this cultural framework is often called out specifically by the term acculturation, and that it assumes and expects a movement of immigrants to align with the mainstream population over time. And this paper criticizes this particular framework in that acculturation is often poorly defined and operationalized, and it is also considered ethnocentric. Another framework that is less commonly used that this review identifies is the structural framework. And essentially this understands and accounts for large-scale social forces that impact health. And they find that the majority of papers that use this framework are focused on healthcare or health outcomes associated with immigration status, including the living and working conditions. I also want to point out this really great paper that was published in 2012, which is how to integrate social epidemiology into immigrant health research. They have a pretty complicated framework that I was going to talk about here, but I think it would just take up too much time. But the gist of this paper is that, the health of immigrants is really embedded in both, where they come from and where they come to. So they're sending and receiving societies. And that, the sending country influences immigrant health before and after they immigrate along the life course, and it can be in combination with receiving country factors. It's a super helpful framework, and I think helps us think about other influences in immigrant health research. So I encourage you to read this one as well. Briefly, in terms of healthcare eligibility for immigrants in Canada, I just start briefly with temporary residents here. So temporary residents are only eligible for OHIP if they have a valid work permit, and also if they have full-time work for more than 6 months in a year. I also want to point out that refugee claimants, while they're waiting their asylum hearing, are eligible for healthcare services and benefits through the Interim Federal Health Program, so IFHP, and they're only eligible for OHIP if they also hold a work permit. And it's probably evident, but we cannot track health service use with using Interim Federal Health Program at ICS because it's obviously OHIP billings and OHIP related use. And if anyone is interested in understanding more about barriers to accessing IFHP, this is pretty well documented by a few papers, but I like this one in particular that's on the screen by Chen. I'd recommend giving that a read if you're curious. In terms of permanent residence, for OHIP eligibility until 2020, there was a 3-month wait for OHIP eligibility for economic and family class immigrants. After 2020, there's no longer a mandatory wait period in Ontario. In terms of resettled refugees, they have always been eligible for OHIP at arrival, and they have additional benefits coverage through the Interim Federal Health Program for the first year after they come. And again, refugee claimants who have a successful hearing and transition to permanent residency um, are eligible for OHIP once they become a permanent resident, and that's regardless of whether they have a work permit. But they also lose their IFHP funded benefits at that point in time. So just to, before I pass it on to Hong, I also briefly just wanted to describe what the distribution of some of these social determinants of health look like for immigrants. And this is based on the public use microdata file from Statistics Canada for the census of 2016. So this is looking at the highest education attained, and the groups across the bottom, the left side are females, the right side is males, and the categories, the bars, are those immigration categories that I talked about in a previous slide. And, I realize this is busy, but if you just want to focus on looking at the darkest blue bars, those are, higher education universally and above, and medicine, dentistry, etc. So if you just look at that, you can see that non-immigrants, which is the column on the most right side of each frame there, you can see that the proportion of higher education is often similar, if not lower, than each of those other immigration groups. So if we, example, compare, females 18.8%, you see that equivalent is 45.2% among economic immigrants, and you go all the way to refugees, which is 17.4%. So very similar in terms of education distribution. If we think about now, I realize this is also busy, but basically what this is looking at is all immigrants together, but then looking at average income in each of the national occupational classification categories. So those are across the top of this graph. And essentially what's this saying is that across all occupational categories, females and males who are immigrants earn on average less than a non-immigrant in that same occupational class. So despite the high levels of education, earning far lower in some cases than non-immigrants. I also wanted to talk a little bit briefly about the language used most often at work. And again, I understand this is busy, but if you just want to focus on the gray part of these bars, you'll see that, there are immigrants who have use a non-official language at work, and it varies by immigration category. But for example, even economic class immigrants, 3.8% of them you don't use English or French at work, 6.6% of family. And I say this because this may translate into, the need for other language availability in healthcare service. In terms of looking at visible minority status and those racialized populations, the left side of this graph pie chart is visible minority status among immigrants. The right side is non-immigrants. And just to say that immigrants as compared to 11% of non-immigrants. So largely immigrants to Canada are considered themselves groups, racial minorities. And before I pass it on to Hong, I just wanted to briefly talk about, these, again, just getting at the roots of, the possibly disproportionate experiences in healthcare service is perceptions of discrimination. I can't find a ton of research in this area, but I did find this one paper that I found useful. And it did both a literature review as well as key informant interviews. And the literature review essentially said that, most discrimination experienced by newcomers in Ontario in healthcare service use is subtle. The key informant interviews indicated that, interpersonal discrimination, so between the healthcare provider or staff at a healthcare office and the individual, can manifest in terms of denial of service based on language ability, their insurance type, as well as discrimination based on their accent or the language they speak. The effects of this is that it leads people to not access services, change their healthcare providers, seek, healthcare and medications from other countries, seek alternative forms of healthcare. And in terms of systemic discrimination, the key informants indicated that, this manifests in terms of a lack of information available to immigrants about the healthcare system, as well as a lack and underuse of cultural interpreter services. So just to briefly recap my section before I pass it on to Hong. So we're thinking about how immigration fits into the social determinants of health framework. Immigration is dictated by public policy, specifically macroeconomic and labor policies. Immigration policy reflects the beliefs and attitudes about who is and who is not a preferred Canadian, and that's been the case throughout Canada's history. The health of immigrants is structurally determined at arrival. It's highly selected across those immigration pathways that I talked about. As well as when we think about understanding the structural and social determinants of health, of immigrant health, that structural framework is not commonly used. We can think about the pre-migration, the transnational, and the post-migration context shaping the health of immigrants. And just in terms of what immigrants look like in terms of the social determinants of health that we can't typically access in ICS data is understanding that immigrants today are largely members of racialized groups. They're highly educated, but generally have lower incomes than other Canadians. So with that, I will pass it on to Hong.
Hi, thanks, Susitha. That's very informative. Yeah, even we work together, I also learn a lot from your slides. So now I will talk about IRCC data at ICES. Yeah, first I will talk about our current IRCC data. Current IRCC data actually is the Ontario portion of IRCC data, permanent resident database. So why people will wonder why we call CIC IRCC, because the Canadian federal government department, formerly called Citizenship and Immigration Canada, CIC, has been renamed as IRCC in November 2015. So this is why we combine these two names together. And so the CIC IRCC data include immigration application records for people who initially applied to land in Ontario. So current database are from 1985 to until September 30, 2020. So from this, my description, you can realize immigrants arriving before 1985 cannot be identified in our data set. This is one limitation. Another is some immigrants who are currently live in Ontario but originally landed in another province. For example, the first land in the Halifax, and then after 3 years moved to the Ontario, they will not be identified in our current IRCC data. So next. Because the immigration is only the records for immigration, so in the ICES, we use data set, we always need to have a IKN, right? So how the immigration data linked at ICES?
Sorry, Hong, should I have not advanced it there?
Yeah, that's fine.
Okay,
the
sorry.
data linkage was used to link the CIC/IRCC data to the RPDB and then obtain IKN where possible. And so most of the methods are determinist record. This means you will link the immigrant categoric full names like first name, middle name, and the last name, then birth of date and sex with the RPDB. If these three matched, we call deterministic linked. So you see majority are determinist linked, but there are something we have like maybe the middle name different or something from the RPDB, then we use the probabilities link, get another IKNs. So from this, you can realize because the RPDB are the people who ever have a health card in Ontario, then you will have a record in RPDB. So if the new immigrants who landed in Ontario and immediately moved to another province will not have an Ontario health card, are not linked in our database. And also, of course, if the people who come to Ontario land, they feel like I want to go back, so of course they won't be in our database. So this is why we always got around 18% missing in our database. So next slide, please. So here I have a paper published from the ASHI group. they show overall linkage rate between IRCC and RPDB was 86%. Around 68% are deterministic linked, and 18 were linked probabilities linkage. I think this linkage is pretty good. So then what's the IRCC data tell us? So IRCC data actually provide the permanent residence card demographic information, includes sex, birth date, age. And I don't mention here. You can see there are some also specific by this permanent resident data elements. Immigration category, that's fine categories. We can roll up to the common category. I will talk this detail later. Family status, principal applicants, are you the parents from the or child? And education qualification and arrival. This is as a system that's very important for the get point. School, year of school at arrival. And also another point is Canadian official language ability at arrival. This variable normally have only 4 values: English, French, bilingual, or none, any of them. Mother tongues, we have hundreds of different mother tongues. Country of birth, country of citizenship, we have nearly more than 200 various different countries. And can be translated as years of permanent residence. This is actually the landing date. So when you plus service use date minus landing date is duration of the permanent resident, length of stay. So those variable, actually, they have a very, very few missing, less than 1%. Some variables have no missing. You can use all of them if you are interested for your study. There are some variables like national occupation classification. Indeed, although I feel like I did the most of the with IRCC data, but I never use these variables because they are highly missing and a lot of not meaningful values. There are also some in the latest, like refugee, Syria refugee flag. This also in the latest data set. And how this CIC, IRCC data is structured. Since IRCC data come in the 3 different periods, CIC is from the January 1st, 1985 to December 31st, 2012. I think this data is arrived 2017. And then we got IRCC data in 2018, is from the before 2031st, 2017. And in the 2021, we got another new IRCC data until September 30, 2020. IRCC actually use this data, cover the whole entire data range. So you don't need to go to the different part. So then I want to give you an example how you use those variables. Yeah, so the first example I will talk about most important, the immigration category. You can see when the different time periods we got data, they actually code totally different. Before 2012, all immigration category have a 3-digit code. And around when they just renamed to IRCC, this period, we got the immigration category code 4-digit. And so the latest we got is actually 8-digit. So yeah, you may feel like a headache. So no worries. IRCC work hard to make our life easy. So use IRCC, please. Next slide. Yeah. So our group worked very hard to create IRCC immigration category format. There are 4 different formats. Use those format can corresponding to the IRCC grouping, which as Susitha described before. For example, overarching format can be distinguished immigrants refugee, and others. Then Big Five can further describe the immigrants as a sponsor family, economic immigrants, and the research categoric, and can be subdivided refugee into resettled refugee and protect person in Canada. And for the more detailed research subcategoric, can even divide resettled refugee into different sponsorship, like a blended visa and government sponsor, private sponsor. And for the asylum protect person can be into asylum seeker or their asylum seeker refugee dependent. For the other immigrants can be also further described. So use this format, the researchers actually can define immigrant category group as what you want. So another important variable is the country variable. So there are two country variables, country of birth, country of citizenship are in ICES, and country values are also not consistent across the year of database. In the before 2012, all country code 3-digit, and in the after 2012, there are 4-digit. Even with the not just the digit different, also the description you will find also different. For example, the first row in the description CIC, they call benign people of Republic of, and in IRCC, they call benign Republic of. So when you just use the IRCs provide the country of citizenship as a format, you will get this format. So we highly recommend people use the another country format. Next slide, please. Country group. So use format CIC country group will take care of what we described before to be one country, and also some historical country will be like, for example, German Federal Republic of Germany, and also Democratic Republic. So use the country group will be one country, Germany, and also British. When you use the citizenship format, you will get different country name, but use the country group, you have a United Kingdom and the colonies. So I don't go to all the detail, just encourage people, if you want to use the country names, yeah, use the CIC country group. And because country have 200 countries, sometimes you don't want to show as a races or the study, you don't want to so granularly. So there are region format also for the country variables. One is the vote area. That's the most, have 6 regions, like Africa, Middle East, Asia, Pacific, and Canada, Europe. So sometimes you don't want to so broad, you want the more detail. So then you should use the vote area region. This actually provides 24 different sub-regions, more details. So researcher can actually combine. If you feel like too much, you can combine as what you want. For example, if you want to like Ocean, Asia, unspecific today with the other Asians, you can always combine by yourself. And for the people like to use the CIC, old data, there are vote bank regions, 7 regions. This actually got from SCC AI code. We actually create CIC, IRCC country SCC AI format to match all the different country code to the SCC AI code. So then you can got vote bank regions. And another thing, since people are interested, we're always working on you want to see how the immigrant health status, we need to know the health coverage. Here, I did some little bit document for our data set. This is the link with the OHIP eligibility. You can see when is the first date of eligibility for immigrants compared to the landing date. There are some missing eligibility. Even we have IKN, but they don't have a record in our eligible data set. And there are 20%, 21% have a OKIP eligibility before landing date, and there are 19% around landing date. And there are majority have a 34%. They have a 19 days waiting period. Some, have a eligibility after landing date. Further, I did for the look at the immigration category, how their OKIP eligibility covered. So next slide, please. You can see for the economic immigrants and spouse family, their majority have a 90 days waiting period. Of course, we got it different because the policy also changed over time. But for the protected person in Canada, risk corresponding to the Susitha described, if you have a submit your asylum and waiting for the hearing period, you actually, if you have working permit, you actually can get your OKIP card before even your hearing approved. And for the resettled refugee, the majority will get their OKIP eligibility around the landing date. I also look at next slide, how the OKIP eligibility changed over the time. As I described, since majority should be around 19 days in the latest period, but you can see in the early period, the most immigrants, they got OKIP eligibility when they arrived. And also in the 2020 is exactly as because of COVID, Ontario have waived immigrants 19 days waiting period. So people ask me the questions for the landing date or start eligibility, which one should be as index date? I often said this will depend on your project objectives, because if your project is research for the Canadian immigrant policy, obviously you need to use the landing date, or first, then you will get. But for the peoples, if they are interested when they arrive in Ontario, have a OKIP eligibility, then you will be either use the latest landing date or start eligibility, which one come latest. You can as your index date to get all the health coverage. But sometimes you want to have a length of the stayed in the immigrant for the people stayed in Canada. So you will use the minimum from the landing date and all start eligibility as your index date. So it's totally depend on your project objectives. So from our current IRCC data, you can see we have some limitations. Some immigrants from another province, they are not in our data set. And also some new variables. Actually, IRCC provide us, we cannot use it. So the good news I want to announce is new IRCC data actually now is in our house. We got 2 periods data from IRCC. One is called legacy data before 2000, and another one they call new data after 2000. Both 2 data sets actually complete structure different as our previous data set. The good things, we have a new linkage method called data flex. Next slide, please. So this is a code from our staff meeting. Our old called the auto match linkage software need to have lots of manual review, even with the 113,000 ORGD. They need personal times 150 hours. But with our new data fuzzy matching, we only need 1 hour. So you can imagine for our immigrant data set, we have more than 3 million records. With the old one, this is why every time we got data set, we only work on that period. We don't do from the whole intern, but with the new data flags, this time we actually can work for the whole data set. And I'm proud ICES continue to be excellent. In 2022, you can see with the new data software, you feel like we actually sacrifice some linkage rate, but with they changed some method actually to improve the linkage rate. You can see with the new data, compared with same peers with old data set, we actually have a higher data linkage, 87.8% compared to the 86.9%. So our new IRS data now in the house, and we are just working on to finalize and documentation to make more convenient for others to use the new data set. The latest landing date is also very new. It's March 31st, 2023. We also have a new variables, application number, across all the period. So the application number, if the people, family, they're all person on a given application, family and extended family, if they are in the same application form, they actually have a shared common application numbers. This variable can be potentially used as a family identifier. And also in the new data set, they have a flag for temporary resident who transition to the permanent resident, ever work permit, ever student permit. Another good news is we also got the national files. Use these national files, we can identify immigrants re-migration to Ontario from other provinces. This can actually fill the gap. Our current IRCC limitation will be if the people, the first landing in the BC come to the Ontario, in our calendar will be non-immigrants. So with this national file, we can actually reclassify as immigrants. And also, we have a temporary resident file include who have a temporary permit and never become the permanent resident. So some research may be interesting to study these files, can give you opportunity. So stay tuned. We are working hard to post those data as soon as possible. We first will post the Ontario portion that we already verified and know how to use it. Stay tuned, and we will try to post as soon as possible. Yeah. Okay, let's go to the Susitha.
Thanks, Hong. I'll just briefly mention the guidance documents that folks at ICS have been working hard on for many years in relation to anti-racist approaches to research and analytics at ICS. In the interest of time, I'm not going to go through these in detail, but just to say that, if you're using the immigration database and you're thinking about, what this might mean in terms of social determinants of health, you're thinking about immigration as a social determinant of health, I really strongly encourage you all to read the guidance in this document. There are variables that people often think of in relation to race and ethnicity, such as country of birth and mother tongue, that are where there's guidance in this document to help you think through what this means. So I'm not going to go through these bullets, but suggest that that's a useful document for anyone. And then I'll just quickly go through the use cases. So these are some forest plots. I'll present some work that Hong and I have done with the team here, including Astrid Gutman, looking at COVID-19 mortality and vaccination coverage by immigration category and region of birth. So this is unpublished results, and these are currently under review, but this is looking at COVID-19 adult mortality, and this is before high population vaccine coverage was achieved in Ontario. So between January 1st, 2020 to August 31st, 2021. And what's in this forest plot is those immigration categories. You see refugees, sponsored family, economic caregivers, and other economic immigrants compared to other Ontario residents. And you can see that COVID-19 mortality was 3 times higher for refugees and economic caregivers, for example, compared to other economic immigrants. So you can see, if you think about how these categories are socially structurally determined, you can see the value in looking at COVID-19 mortality according to these categories. We did another analysis, again, looking at immigration category, but looking at COVID-19 mortality after high population vaccine coverage was achieved. So up until April 30th, 2023. And you can see that COVID-19 mortality drastically reduced for almost all of those immigration categories, except for refugees, which remained at higher risk of COVID-19 mortality. I'll present to you 2 forest plots looking at very disaggregated regions of birth. And this first graph is related, again, to adult COVID-19 mortality. The orange circles are pre-vaccine era COVID-19 mortality, and the blue triangles are vaccine era. And just to, demonstrate the importance of really disaggregating those regions of birth and having some understanding of why you're using certain categorizations. We had a specific rationale for this, which I won't get into, but you can see that there is a lot of variability within regions that are normally aggregated. So like, for example, Caribbean, here we disaggregated between Jamaica and other Caribbean and Bermuda, and you can see that, the pre-vaccine mortality between those 2 regions was substantially different. And the forest plot is kind of structured geographically, so you can take a look at this. But that's just to show the power of disaggregating these regions into demonstrating substantial variability. We also did some work looking at COVID-19 vaccine coverage. And this is by a colleague of ours, Julia Brandenberger, looking at pediatric coverage, so children and adults. And again, the regions of birth are slightly different for a rationale we provided in the paper. But just want to say that in addition to looking at disaggregated regions of birth and the importance of doing so, we can also look at second-generation immigrants, and that's because of the linkage between that's possible between the mom-to-baby database and the immigration database. So we can identify immigrant moms who gave birth to children in Ontario, and totally acknowledging that is a limitation that we can only identify the mothers. We can't identify immigrant fathers as well. But this is just to show you, the power of linking databases and looking at region of birth in this way. And with that, I would realize we're 2 minutes over. Elise, I'm not sure if you want to jump in here or whether we can answer questions.
Yeah, thanks so much to all our speakers for offering these insights on, how many different intersections we need to be thinking about within our IRCC data and where our opportunities are to disaggregate. It does look like the time demands that we close up. So just acknowledging that some people may have to hop off, I'll offer a couple closing comments. But Susitha had very generously offered to stick around after time. So for those who are able to stick around, if you have a burning question, you're welcome to do so. If you have a burning question but need to hop off, feel free to leave it in the chat or in the Menti, and we'll make sure we get it answered and get that information out to you when we can. So again, thanks to all our speakers for sharing their expertise. Thanks to all attendees for your engagement in this topic. Today's recording, as well as any unanswered questions that we need to address later, will appear on our dedicated intranet page. I'll paste that in the chat for those who may not be familiar. I wanted to let folks know as well about a new opportunity from the Science Office for those who'd like to continue the conversation at a project-specific application level. Dr. Arjuman Siddiqui, who's also a social epidemiologist and is the Canada Research Chair in Population Health Equity, there's some opportunities to chat with her. So our March and April appointment slots are actually already fully booked, but her next available is May 14th. So link in the chat there to where that information lives if you'd like to sign up. So thank you all again, and take care. See you next time if you have to go.